And here we go. Don't worry, I can always trim the beginning of it. All right, the waiting room is disabled, and welcome everyone.
Thank you. Thanks, Scott. This is Scott. Start. Good.
We can give people a minute to show up, or I think it's just in case there's any stragglers or something.
All right. I'll wait for you to say go.
Yeah, there's lots of people that are hopping in now, so let's give everybody a minute or so. Hello, everybody. Thank you for joining us. We'll be getting started here in just a minute. If you haven't attended one of our webinars before, there will be a Q&A session towards the end. So feel free to type in your questions into the chat, and we'll be sure to get those answered. You're free to unmute your microphone during the Q&A session as well, if you like. Just please keep it muted during the beginning portion. I think we're good to go, Glenn, whenever you're ready.
Thanks, Scott. I'm Glenn Sykes. I know I looked at who's on board. I see a lot of familiar faces. It's nice to see you again here tonight. Thanks for taking a chance on this topic. I think we're going to have a great session. I'm a person living with kidney cancer. I was diagnosed in December 2010, became metastatic in June 2015. I've had any number of treatments, local, systemic, ranging from old-fashioned high-dose interleukin-2 to more recently belzutifan and Nivo and Ipi. So pretty active member of the Judy Nicholson community, as well as smart patient community, which I also recommend if you aren't on there. It's been a really useful resource for me, and I hope it will be for you if you haven't made it on here yet. I'm not going to spend too long in introductions because I want to move to our guest speaker. Dr. Pallavi Kumar is the Director of Oncology, Palliative Care, and Assistant Professor of Clinical Medicine at Penn Medicine at the University of Pennsylvania here in Philadelphia, which is where we both are at the moment. She's been in palliative care practicing for 9 years. In addition to that expertise that she has, she also is a medical oncologist for GI cancers. She did her training at Duke University School of Medicine. And I know, in fact, that you're going to enjoy hearing from her tonight. So welcome, Dr. Kumar.
Thank you so much for having me.
You're welcome.
Glad to see so many people.
So for the next 30 minutes or so, what I'm going to do is toss out some questions to Dr. Kumar that we talked about ahead of time to make sure that we all have a solid understanding of palliative care. And then we'll turn things over, as Scott said, to your questions. You can put them in the chat room. And also, when we get to that question part, I'll see if anyone has any live questions that would like to ask those. For the part that I'm here leading, what I like to do is I've thought about it in 3 sort of sections. One section, just to give patients and caregivers that are on the line to be better informed about palliative care and to accomplish the following, which is giving you the basics about a topic of which I think there is sometimes misunderstandings or low awareness of, which I assume has driven some of you here today. So, and once we get the basics out of the way, kind of fill in some more details to make that a fuller picture for you. And then at the very end of my session, I want to do is kind of provide Dr. Kumar a chance to tell us what should we do next if we've decided that we've heard such exciting things, worthwhile things for our own life, what we should do next to act on that. And then we'll turn things over to your questions. So with that, what I like to do, hopefully that sounds all right to everyone, start with, until I did some investigation, and full disclosure, Dr. Kumar, I started to see in March of this past year. And so I know her from that time. And so I am seeking palliative care. But until I did some investigation, and this may ring true for some of you, when I came across someone being referred to palliative care, or I read about it in my smart patient community, I assumed it was sort of the last days for this person. which meant seeking out palliative care, felt like a big thing. I was crossing some line, and when I told people, my family and friends, I was seeking palliative care, that I was signaling to them that I felt like I was crossing some line. So it was sort of a heavy burden. Dr. Kumar, have you come across that kind of thinking from some of your patients? And then if you could follow that up, is what kinds of things do patients come and talk to you about?
Yes, absolutely. I think it's probably the number one problem we have in palliative care is that people assume, because they've heard from a variety of sources, that, oh gosh, if you're going to go see palliative care, they must be stopping everything. I can't tell you how many times I walk in the room and someone's literally white knuckling, they're holding the chair so tight that they are actually white knuckling it until I walk in the room. And then, we talk and hopefully, take down some of the anxiety. I can't blame anyone for thinking this way, right? So the fellowship itself that I did is called Hospice and Palliative Medicine. So certainly it's been linked traditionally. And so what I would say to most people is all hospice is palliative care, but not all palliative care is hospice. Palliative care is a very big umbrella, and hospice is but one part of what palliative care can offer. So I've come across this thinking quite a bit, and it's not just patients. It's a lot of my referring colleagues. Culturally, at sort of these ivory tower academic institutions, people used to say, it's not time for palliative care yet. I don't need them. I have so many different treatments I have. Why would I need them? And so we get this thinking even from our fellow colleagues who are trained in medicine. So it's a universal branding problem that we have in palliative care. In reality, when I walk in the room and I tell people what things I can help with, it takes the, sort of danger level down quite a bit. And so what I usually tell people is these are the 3 pillars of palliative care. You tell me if any of this resonates with you. Number 1, we're here to help with complex symptom management, whether that's pain. A lot of times it is, but sometimes it's other symptoms like fatigue or nausea. Number 2, I'm here to offer, and my team is here to offer, an extra layer of emotional support as you're coping with a serious illness. And number 3, we're here to help with, planning for the future. If that's something that makes sense, it may not make sense right now to actually even talk about that, but I'm here to help with that if that makes sense down the road. And as soon as we say that, usually people are like, can breathe a little.
Right. I imagine it gives them the things that are going on in their head. They can begin to start to put, categorize them for what they're there. I know I don't. Hopefully, I wasn't white knuckling, but I probably was thinking, "Gosh, what am I going to do here?" And felt a little nervous about that. If those 3 categories, which is great, complex symptom management, an extra level of support, and then planning for the future. This may be difficult, but if you could think about those categories, what do patients most often come to you about? How would you rank that list?
I would say number 1, 2, and 3 on the list are symptom management. That's how people get in the door to see us. And quite frankly, I don't know that we have any business talking to them about the future or coping until we help them with the more immediate problems, which usually are physical symptoms that are bothering them and keeping them from having a good quality of life. So I would say 3/4 of the patients that we see, symptom management is on the referral, as this is one of the top reasons. I would say 25% get co-referred for emotional support. And I would say it's probably only about 20 to 25% that somebody's writing down, would like to plan for the future. So far and away, symptom management is the most common reason to see us.
Right. And does that feel right to you? An obvious question I'm having as you talk about symptom management is, and we talked a little about this when we met, is medical oncologists. Aren't they providing that help for symptom management?
Great question. So one of the other things we always tell people at the first visit is, don't worry, I'm not replacing your oncology team. We do not supplant what they do. We are just enhancing what they do. And I think anybody here who's attended an oncology visit can attest to sort of the fast pace of those visits, right? You're getting in the room, you're waiting an awful long time sometimes. You're running through toxicity, you're reviewing labs, you're reviewing scans, you're refilling meds. there's so much work that happens in an oncology visit. Sometimes you don't have the extra time you need, both as a patient but also as a clinician, to delve a little bit more into, okay, your pain's not well controlled. Why is that? How many pills are you taking a day? When is the pain? Really sort of in-depth symptom management. Sometimes that needs extra time.
Okay.
Sometimes it's not that the oncologist can't do it. It's just that we have a little more space in our visits to dedicate to that. And then for really complex pain management, where we're starting meds that oncologists don't usually start, I think they should see a specialist.
Okay, good. Thanks for making that clear. I'm sure it's hard to generalize, but I'm going to ask you to do it anyway. When patients come in to see you, where are they in their cancer journey? Were they diagnosed last month? Are they in that case where, it is the last days, or is it, somewhere in between?
It's a great question. It's something we talk about all the time. I would say 9 or 10 years ago, when we sort of hung our shingle at Penn and started our clinic, we were seeing way too many people very late in the course of their illness, where we felt like we were doing acute crisis management and hopefully helping them. But we had this overriding sense of, gosh, I wish I had seen you 6 months ago. I wish I had seen you 12 months ago. And it wouldn't feel so abrupt and intrusive for us to just come in and say, here, we're here to help. So things have changed, and even the culture has changed. Even in the decade that I've been here, we're seeing more people early in their cancer journey. There is good evidence and actually cancer guidelines from both ASCO, our American Society of Clinical Oncology, and NCCN, which is the National Comprehensive Cancer Network. Those probably are the two big societies that put out guidelines for clinical care. And they're saying, for example, lung cancer patients, all patients with stage 4 lung cancer should meet palliative care at diagnosis. That doesn't necessarily mean the first visit, but it means the first couple of months they should be meeting us. It's not always feasible. It doesn't always happen for a variety of reasons. But if that's the guideline, I think we're seeing oncologists say, hey, I should refer this person now. And so we're meeting probably, I would say 25% of our patients, or maybe a little less than that, maybe 15 to 20% of our patients, we're meeting them at diagnosis, which is great. Yeah, which is actually great for us, because then we can have a relationship. And the truth is, treatments have come a long way. And so when we meet them early, they may be having some symptoms from their cancer, but we get them, their oncology team gets them on treatment. We tweak some, medications, but now they know us, and we're not this foreign, entity, so that down the road, if they need us more in the future, if the cancer treatment doesn't go the way we want it to go, they already know us, so we can step in to help, and we're not this brand new, group of people like, oh gosh, who are these people coming in now? I would say probably solidly 60% of patients we're meeting somewhere in the middle of their cancer journey. They've seen a couple of treatments, symptoms are escalating a little bit, and onc is saying, hey, I've used the tools in my toolkit, I need you guys to come in and help. So We're seeing the vast majority of patients are somewhere, in the middle of their cancer journey. We are, we're still lamenting that we're meeting people late in the course, though. So It's something that does keep us up at night, that, gosh, I wish I had met this patient even 3 months ago, even 4 months. I could have maybe helped a little bit, or just allay some of the anxieties that were there.
Right. Yeah, I think that, I don't know that I necessarily read those guidelines, but I think that's what drove me to ask about seeing palliative care, was thinking about a crisis moment, and would I want to be meeting someone like you for the first time? Nothing personal, but
Absolutely.
My personality, no, I'd like to know this person and have a relationship with them before I got that. So it drove me in to see you earlier. But let me talk about also the 25%, I guess the related not to symptom management, which sound a little bit like, maybe you get a prescription pad. I'm not sure exactly, and we'll come back to that. But I'm thinking about the 25%, which are a little bit different. It sounds like there's a lot of talking, you're going on in the room between you and your patients and your caregivers, I guess. How would that compare to talk therapy? I go to a support group, or I go to a therapist and talk through some of those things about, emotional support, planning for the future. how do you feel? What do you view as distinctive about what goes on in your room?
It's a great question. So we address coping at almost every visit, and certainly even at our first visits, even if someone's being sent for, pain or nausea or fatigue, the question comes up because it's just a way to connect with people, and it's something I want to know. Honestly, I want to know it when I'm their oncologist. It's not just a question we ask when I'm wearing my palliative care hat. So it's sort of the human side of the connection that we have with our patients, right? So we're going to ask about coping. We're usually pretty clear that, we're not therapists. I certainly don't want to, say that I have skills that I don't, but what I can do is assess how someone's coping, what coping strategies are they using to deal with a serious illness, how is that serious illness fitting into the rest of their life, and should we be making another referral? Should I be referring this person to a counselor, a therapist, a social worker, maybe a community pastoral care person? A lot of people cope using faith and spirituality, and I want to make sure we're assessing not just coping, we assess sort of spiritual or existential distress, try to make referrals that are appropriate for each situation. It's different from talk therapy because I think we're placing all of the feelings, the coping, the distress in the context of the serious illness. So okay. Just as an example, a lot of people, when they have a cancer diagnosis, come and see me and say, it feels like everything's out of my control. I mean, you guys basically tell me when to be there, how often I have to be. I mean, I have no control. So we strategize about sort of what are some behavioral strategies. We're going to make some concrete, I'm going to give you some homework. If you feel like all day you're spending just sort of from treatment to treatment, that you're just week to week, you're just sort of waiting for the next treatment, there's no structure or purpose to the days, we come up with some concrete strategies, like we're making a schedule. You have to plan a fun thing this week. You need to do, an hour of something every day that gives your day a sense of purpose. And so that's actually sort of like a coping intervention, maybe not the same as what you would get from a talk therapist. So we're trying to ground it in, what's going on with your health.
Yeah, that fact that things feel out of control, so it rings true for me. And Dr. Kumar does give homework, because she gave me some homework for my next appointment. Oh, it's true. So good. You said something, and I want to ask you, you're a medical oncologist, which I realize not all palliative care doctors are medical oncologists, as far as I know. You are, but you also have a palliative care specialty practice. So, I have this image of you, saying, well, today, this is my clinic in palliative care. This is my clinic in oncology care, and they're really distinct. And that might be the wrong impression. In fact, I bet you there's a lot of fluidity between those two. Maybe you're always wearing both hats.
It's great. It's a great question. So specialist palliative care is different than what happens in an oncology visit, but the secret is every oncology visit has some palliative care in it. We just don't call it that, right? So when your oncologist reviews anti-nausea meds and a bowel regimen and make sure that you understand what you're supposed to be doing, that is actually palliative care, because they're doing symptom management. When your oncologist is checking in with you about what important events are coming up this year that we need to plan for so that we can time our chemo around, the wedding that you have to get to, or the graduation you're hoping to feel well for, building that rapport, understanding what gives someone's life joy and meaning and purpose, that is actually palliative care. I would say it's palliative care, but it's also really good oncology care. So I like to say that we should never be replacing the supportive care that you get from your oncology team. We should just add to it.
Okay. Thanks. I'm amazed at probably the amount of knowledge, just for an oncologist, and then you added palliative care, that you must possess in your head. But let me ask another question. Are there matters that you're not going to address in the palliative care appointment?
That's a really good question. I think every field is changing so quickly, and we physicians, clinicians in general, love evidence, right? So to keep up on the evidence, for example, diabetes management has gotten so much more complicated. I'm an internist by training, so I did internal medicine training, onc training, palliative care training. So I am never going to let someone leave my office who has a blood pressure of 200 over 100 and not say, either you need to do this or I'm going to call your primary. I'm never going to not address it, but I won't pretend to be an expert in that. And I'll say, hey, I need you to not stop seeing your primary care doctor because we need your blood sugars to be under better control. Because if I need to give you steroids for this, whatever this symptom is or whatever, I need your blood sugars to be under better control. So we do try to make sure that we're keeping our primary care colleagues looped in. Or, for example, if someone has had a long-standing kidney issue that they have a nephrologist for, we won't go and sort of make recommendations without talking to the kidney doctor. Similarly, this actually comes up a lot in my practice. Someone has had a long history of, whether it's severe mental illness or other reasons for which they see a psychiatrist. I won't go sort of looking around with their medicines and it's sort of disrespectful to this longitudinal relationship they've had. So we try to be careful when we're talking about sort of consult etiquette to make sure we're not just going in and changing things without making sure everyone's on the same page.
Right.
We get this complaint from primary care doctors all the time. When I say we, I mean oncology teams. They say, we send you guys our patients that we've known for 15 years. You don't even send a note back. So we try very hard to make sure we're closing the loops with these really important clinicians.
Right. Since we touched upon the topic in the very beginning, and what you said consistent with why I've always have heard since I started focusing on this topic, that hospice is a subspecialty of palliative care. Palliative care is the broad heading. Hospice is a care, and as we talked about in the beginning, often is confused. People throw them all in as the same thing, and I thought that for a long time. Would you mind? I know, maybe your specialty isn't hospice, but could you touch upon that? Because I think that's probably something people have in their mind right now. What would be hospice care?
Yep.
How's that different?
And folks who are doing palliative care are boarded in hospice and palliative medicine, so it is part of the same boards.
Okay.
We sit in the same boards. But I would say, when you define palliative care, it's really specialized medical care for anybody living with a serious illness. It's not limited to the end of life. It is appropriate at sort of any stage in the cancer journey, for example. We're focusing on cancer today, but palliative care is very appropriate for folks with advanced lung disease, end-stage renal disease, liver disease, heart failure. All of these are diseases or conditions that would greatly benefit from palliative care. Cancer has become more integrated with palliative care because we were sort of the original partners for palliative care. It's a no-brainer that patients with cancer are experiencing pain and nausea and fatigue and appetite loss, so it was a natural pairing. But truly, all of these diseases could benefit from palliative care involvement in some way. Hospice care is really, when you think about what hospice is, it's actually a Medicare benefit, right? And so Medicare has defined two benefits that are available to sort of all patients who receive Medicare. And that dialysis is one of them, which we won't cover today, but hospice. And so what is hospice care? It is comprehensive care, usually delivered in the home setting for anyone who is estimated to have a prognosis of 6 months or less with a serious medical condition. They say terminal medical condition. I don't love the word terminal in general, but a serious medical condition that, might shorten life to 6 months or less.
Right.
Vast majority of that care is delivered at home. Sometimes people are under the impression that hospice is a place, and there are inpatient hospice facilities, but the vast majority of Americans who receive hospice care get it in their home.
Thanks for that. I often hear a lot of confusion about that. In fact, last night at dinner with friends I was talking about tonight, they immediately went to that end of life understanding of what palliative care was, and looked at me as well when I said that, wondering about where things were with me. But I wanted to. Oh my gosh! My thought just went out of my head. Maybe I'll come back to that. So let's talk about what happens on a palliative care appointment.
Sure.
Many on the call, as we said in the beginning, are very familiar with what happens in the oncologist appointment. Probably spend more time than we care to in those appointments, but we have less experience with palliative care appointments. So walk me through what happens in an appointment when someone comes to you.
Absolutely. And so usually before the appointment, we try to spend a little bit of time reviewing someone's oncology history. And because we're a dedicated palliative oncology clinic, we're just talking cancer. But I always like to look at the oncologists do a very good job of listing out the timeline of what's happened. How did this person get diagnosed? What are the treatments? What have they tried? What are the scans? So we try to familiarize ourselves as much as possible with what has led up to this visit. Both from a cancer journey perspective, but also, what did the most recent scans show? Are things the same, better, worse? What other specialists have they seen? Have they received any radiation? So I really try to get to know a capsule of what has brought this person to this visit today. Where are they in their cancer journey? Have they tried 6 or 7 treatments and not one of them has worked? Or have they just tried the first one and they're actually feeling better? So I want to know where they are. And I think when I walk in the room and I am familiar with someone's cancer history, it immediately puts them at ease because then they don't have to repeat their whole medical history. It's exhausting.
Yeah.
And I can tell. So that's what happens before the visit. I usually walk in and I always lead with, what do you know about why you're here today? Because I do sense the tension sometimes, and you can just see it on people's faces, and you want to make sure that you're meeting them where they are. Some people are like, I referred myself. I read about palliative care in the New York Times. Let's go. I have these issues. But if that's not the case, I usually say, what do you know about why you're here today? Can I tell you what palliative care is? And then I always start with, I have a list of things that in reading the chart, I thought I have to talk about pain and bowels today. I know I have to do that, but I want to hear from the patient what's on their mind, because my list and their list, there may not be a lot of overlap, and I want to know what they're here for today. And so we sort of make a list, and we know that we're probably going to tackle the top, 3 or 4 issues, right? That's usually what you have time for in a visit. So I have my checklist of things. I'm always asking about pain and nausea, bowels, appetite, fatigue. But then I also want to get to who are your support people? And usually they're there with them, but if they're not, I want to know who is in your inner circle. How are you coping? How are they coping? And then I try to get to know what makes the person in front of me tick. I want to know what's important to you. What are we doing all this for? What goals are we trying to achieve? I will often make medication changes or suggestions at that first visit. Because if someone's coming to me for a symptom, it often is managed with a medication. I try not to make more than 2 or 3 med changes at that first visit, because I know my head would spin if someone started 3 meds on me at once. I usually do ask who someone's healthcare proxy is, not because I think anything bad is happening right then, but I always want to know, who does this person rely on for medical decision making if needed. And then people always leave our clinic with, I always either send them through the portal or a paper copy of, this is what we talked about today, for pain, for nausea, these are the things we did. And then a list of sort of our contacts, and then referrals. So that visit with me may lead to, hey, you know what, you need to see nutrition. And we haven't had them see you yet, so let's do that. Or things are going well, but you're deconditioned, let's send you to PT. So we might have them leave with a couple of referrals. And then if they ask for it, or if I think it's really necessary, I will plug them in with our palliative care social worker for a counseling session if it's necessary. So they will leave usually with some physical evidence that they were in my clinic. I want them to leave with something to say, this is who I saw, this is what she said.
Or homework in some cases. So yeah, that's good.
Or homework sometimes.
There's something I want to make sure that I'm clear about, and our audience is clear about, because we've touched upon it a number of times, and I want to hear what you have to say. We've talked about symptom management. You said 75% of your people are coming. 75% of the appointments have to do with symptom management. So let me just ask a really direct question. If I'm not having problems with managing my symptoms, I have no symptoms, or if they're quite well managed, is there a need for me to see a palliative care doctor?
So that's a great question. So there are people who are quote, just referred for distress. And distress, I would say, is, any interference with your quality of life, your mood, because of the medical context, and sort of quality of life impairment due to that sort of distress, I think should be a reason to see palliative care.
Good.
I see people who are, this is not in the solid tumor world at all, but I see a lot of young patients with leukemia diagnoses who are hopefully going to be cured of their leukemia, but in 3 weeks they're heading into the hospital for a 6-week hospital stay for a bone marrow transplant. You better believe there's a ton of distress, and they want to talk about the what ifs. So there's nothing there's nothing wrong. Their leukemia is under control. Their counts look good, but they often get referred because their oncologists are like, the distress level is up here, because they're basically giving up control for the next 2 months of their life. We need them to see you.
Right. Yeah. In fact, I was thinking about last night, dinner with friends. The thing I've heard, and I think maybe in a podcast, is that palliative care has to do with quality of life. So certainly, quality of life can be affected by symptoms. But if I have distress, it's affecting my quality of life. And all I can think about is that 6-week hospital stay or whatever it is on our mind. That impacts quality of life. So I like that when I heard it, because it touches on so many things, I think, that matter. When you meet with patients, how do you meet with them? What happens if I can't get in the facility, or it's not convenient for me? What happens?
Great question. So that has really expanded during the pandemic. So pre-pandemic, it was really hard to get insurance to reimburse telemedicine visits, or to even allow them. And now the whole landscape has changed. So we still see patients, obviously, in person. We try very hard to either do tandem visits with oncology, meaning you're already coming in at 10. For oncology, we'll try to see you at 11. Sometimes we do joint visits with oncology, which are my personal favorite, because then everybody's in the same room saying and hearing the same things. Obviously, that requires a lot of coordination and often a lot of patience on the part of our patients, just to sit in a room and have everyone sort of come in and out. Sometimes we'll pop over to infusion if someone's getting an IV infusion and they're stuck in infusion for 3 hours, as long as they're not getting meds that are really sedating. Sometimes I'll just say, you're stuck with us here. Let's just make use of this time. I don't tend to see new patients in infusion because, if you've been in an infusion visit, it's often in and out, and the nurses are in and out taking vitals as they need to. But if I know someone well, and nothing else works, I'll pop over to infusion to see them. That's, we try to make it work for patients. I don't want someone to come back and pay a separate parking fee. I know that sounds a little crazy, but if they're coming in just to have a talking visit with me, Penn won't reimburse their parking. So I'm pretty
anti-that. For infusion patients, parking is free at Penn. Exactly. So that's a big benefit if you're doubling up on things. Yeah.
Yeah, it's not cheap here. So we try to meet the patients where they are. Telemed has opened up a universe of opportunities. So say someone's on a 3-week schedule, they're only needing to come in once every 3 weeks. They will actually come in and see their onc team and get infusion week 1. They might actually see me telemed week 2, because then they have more frequent touch points, but no more, they're not having to hoof it in that second week. It's like a way to sort of spread the care out a little bit. Telemed during the pandemic also allowed family members to sort of zoom in from places that otherwise they wouldn't have been able to have been part of the visit in the same way. Right. Also, sometimes, when patients are at home, they're a little more relaxed. They're not sitting there watching the clock saying, this is great, I am talking to you, but I got to go to infusion, So sometimes it's nice that people have the leisure in their own home, and we can have, almost as good visits on telemed. Obviously, you miss, there are some times where I'm like, oh no, I need to examine you, you have to come in. Right. But a lot of what we do can be done via telemed.
Thanks.
So those are sort of the ways I see people. And then I would say that, palliative care, some institutions have home palliative care programs where clinicians actually go out to the house, like an NP, sometimes an MD will go out to the house. It's few and far between. And then there are also home palliative care programs, which are largely palliative care nurses who go out to the house. All of that care is overseen by either, an onc, NP, MD, team. or a primary care doctor will be overseeing that care.
All right. One last question until I get to sort of my final list here. You've already mentioned it, but I just want to make sure everyone has a clear understanding. And I'm not talking about maybe what it falls on the organizational chart, but when you think of the palliative care team, I think you've mentioned nutrition, a social worker, potentially, like a spiritual advisor, a chaplain type person. Who else is on that team? Like someone may experience if they're in palliative care.
Great question. So I'll start with ideal state, and then I'll talk about sort of reality. So in an ideal world, palliative care is a team sport. We cannot deliver good palliative care unless we do it in teams. A lone palliative care MD is never going to be doing the type of palliative care that we aspire to, which is, MD or NP care that is like medical care, medications, ordering tests or interpreting tests. Nurses are integral to palliative care because there's so much inter-visit care that happens for us. You might see us, but if your appointment isn't in 2 weeks, we always ask one of our nurses to call. I say one of our nurses, we have one nurse, to call and check in and say, we started this med, how are they doing? And then feed that back to us so we can make changes if we need to. Pharmacists, these are like my goals, is to have a pharmacist to be part of our team because we are prescribing often complex medication regimens. Having a palliative care pharmacist is invaluable. I think spiritual care is so necessary. We do not have an outpatient spiritual support provider in our palliative care team. We certainly have spiritual care for hospice patients, but that is, I think, an area of unmet need and an under-recognized need. We do have a social worker, and our social worker for palliative care functions unlike in onc and in the hospital where they're doing case management. Our social worker functions purely as a counselor, almost sort of in a therapy role. And so she's doing 30 to 60-minute visits virtually, dedicated to counseling. There are others, I think, who you could say could be part of that team. And at some cancer centers, I think they probably do have nutritionists as part of the palliative care team. They have probably psycho-oncologists. If I had everything on my wish list, I would have a psychiatrist who was trained in palliative care. I'd have a psychologist on our team. Oh yeah, I would have all the asks that I could get. I think the reality is that if you've seen one palliative care team, you've seen one palliative care team because they're all different.
All right.
Yeah.
Cool.
Until 2022, we did not even have a nurse on our team. So we've really tried to get, more resources for our team.
Good. Well, fingers crossed you get to more. And I'm going to maybe ask one or two last questions here. So no doubt, most of the, I think probably some or maybe most of the people on this call today are going to think, this sounds great. I'm interested in palliative care. So what advice do you have for people that might be in that position? And I'd like you to bake into that answer, what happens if I I talk to my healthcare institution tomorrow and they're like, we don't have palliative care, or is there anything else I could do as well? Sure. I don't want to just be in the bubble that, as you said, some these large healthcare institutions that do have it. I recognize that there are some who won't. Are there resources available? So anyhow, what advice would you have for someone who's in either of those situations, or probably things in between?
Yeah, no, I think even though a lot of referrals get to us because the clinician seeing the patient for their serious illness recognizes that there's a need, sometimes that doesn't happen. And so if you feel like you would benefit from the services we talked about today, I would say, please ask. I can count probably on one hand the number of times the patient has asked their oncology team for a palliative care consult and they've been told no. I think as we've sort of become part of the culture here, oncology is like, want to see palliative? Great, absolutely, of course. So ask your oncologist, ask your clinician for a referral. You should feel empowered to do that because it is standard part of cancer care at this point. And was that the first part of it? I'm so sorry.
Yeah, and the other part is, what if there's no palliative care at the healthcare institution that I'm getting the majority of my care at?
Yeah. So if there's it's a great question. If there's not a specialist ambulatory or clinic-based palliative care option, someone you can see at the institution in a clinic visit, then I would ask I would ask your oncology clinicians, do you guys have a home palliative care program? Oftentimes our home care providers, even if it's not technically a palliative care program, even a good home care program is doing a lot of the same things we're doing.
Oh.
They're assessing medications, they're assessing symptoms, they're feeding that information back to the oncology team. They're saying, hey, I'm seeing this person in their home. I just did a med rec. You can keep prescribing these meds, but they don't actually know how to take them. So can you help? Like, they can actually be that set of eyes and ears in the home to say, we could be doing better with symptom management. So like I said, even though palliative care has a specific label and a specialty, and there are specialists, it's really just exquisite attention to patient symptoms and symptom management, understanding what we're doing right now, is it working or not working, and then feeding that information back to the people who can, help make some changes.
Good. And are there any, you had given me this homework assignment that came from a publication, it looks like from Dana-Farber. Are there written, and this may be revealing my own biases, I do like reading things. Are there resources that you could send patients or caregivers to that will allow them to sort of think about the mindset of what palliative care is about?
Absolutely. So I would say the thing we bring to the table, in addition to the symptom management, is understanding what patients' goals and values are. That's probably top of my list. Even when I'm doing symptom management, I'm trying to understand what is it that we're trying to get to. Most of my patients aren't saying, I want to get to zero pain. They're trying to say, I'm trying to get to brunch. I'm trying to get to this thing that I really enjoy doing with my friends that I don't do anymore because I'm stuck at home because of this problem. So I think all of our discussions should be goals and values based. And so I am trying to understand what brings my patients like joy and meaning. And I think that's one thing I think we do well. And so if I give homework to people, it's usually along those lines. I want to know, what are your goals? Not what are your medical goals? What are your life goals? What should we be working towards? I also want to know, what are you worried about? What fears do you have? What worries do you have? I want to know what gives you strength. I want to know, what things are so critical to your life that you can't imagine living without them. When I say that, I've heard the range of answers from, if I can't enjoy dinner with my family, that's really not good quality of life. And I have other folks that say, if I can't play 18 holes of golf, I just don't know what I'll do. So you get a range of answers. I also want to know, I want to ask the what if questions, even though they're hard. I do want to know from my patients, what if things get worse? What are things that you are okay with, and what are things that you're absolutely not okay with? Because I never want to look back and say, oh my gosh, we gave care to this person that they would never have wanted. I want to know the answers to some of these hard questions as I get to know people, certainly not a first visit type of conversation. And then I want to know, what's the family context in how you're dealing with this. I want to know, is there a daughter somewhere or a son somewhere that we need to loop in, who just, I have so many patients that say, I don't want to worry them. And meanwhile, this person is, states away and needs to know what's going on, because they would definitely be here to support their, parent or family member. So I want to understand the family context. All of that I would lump into serious illness communication. It's so important. It doesn't happen often enough, and it often happens late. It happens in an emergency department, and it's done very poorly when it happens there. It happens in the ICU sometimes, and we do a terrible job of it, when it's in an acute crisis setting. So I want to have these conversations with people when there's not a crisis happening, and we're not, our back is not against the wall with some medical decision that needs to be made. I just want to get to know people outside of a crisis context. So serious illness communication is really important. We need to do better. And that's why I give my patients homework. So, I actually give them a sheet that says, I need you to think about the answers to some of these questions so we can talk about this in a relaxed way when there's nothing else going on. So there are some websites that I think are really helpful. I can put them into the chat.
Thank you. Yeah, so it could be even, it can be a simple, you listed some questions that patients can ask themselves. So it could be as simple as just getting a piece of paper out or an iPad or a typewriter and answering some of these things would be helpful. Good. I want to turn over to the chat. I thought as we were talking, I did see some questions come into the chat. So Scott, can you take us to that point?
Yes, sir. The first question came from Deb Parker. She asks, if fatigue is currently the only symptom, is a palliative consult appropriate versus seeing the patient's PCP?
Gotcha. I'm going to give that maddening answer, which is it depends. um, so, and I'm going to assume that oncology is doing all of their due diligence. You know, they're checking a hemoglobin and a thyroid. They're doing all the usual medical workup that any oncologist would do to make sure there's nothing that is reversible or you know that we should be doing medically. If the fatigue is really due to cancer treatment or the cancer itself, or deconditioning because you know the chemo is really beating someone up a little bit, I think absolutely appropriate to see palliative care. I also think it's appropriate to make referrals to people like cancer rehab, which at our institution is physiatry, or PT. So I always think if you're dealing with a global symptom like fatigue, which is affecting quality of life and is almost certainly related to the cancer, absolutely refer to palliative care, and we'll handle whether meds are appropriate, what other non-pharmacologic things we can do, and referrals out. We'll refer to PT. We'll say, cancer rehab, we need you to see this person. So absolutely palliative care is important. If it's very clearly a thyroid issue, maybe the PCP wants to adjust the thyroid medication, and that's great. I will say that's the minority of situations. I think fatigue is a very appropriate consult for palliative care.
Thanks.
The next question came from Bill Hoffman. He asks, is palliative care performed in the patient's home or in a clinic office?
I think it could be, as we talked about a little bit, you know, I think many large cancer centers have an outpatient palliative care program. I will say that a lot of smaller hospital systems do not. And so it really depends on where you are. We have patients that even though we're here, either they cannot do telemed, they just can't participate in telemed, or are so weak that they can't come into the office, in which case home palliative care makes a lot more sense than saddling them with a trip into Philly. So it really depends on the clinical scenario. It can be either or both.
Thanks. And Bill, it's great to have you here. Bill was one of the brave people that I gathered in April to do a little what I didn't realize was going to be the time, but a little focus group on topics that we wanted to talk about when we think about the future that we wanted to have a little bit more focus on. And palliative care was sort of at the top of the list, which explains why we're here tonight. So it's good to hear from you, Bill. Scott?
Yes, and the next question comes from Julie. And anyone who has questions, feel free to type them into the chat, or in a few minutes, we'll allow you to unmute your microphone as well. But Julie asks, in my clinic, we have a nurse navigator. Is this the same as palliative care?
I think if this person is an oncology nurse navigator, typically not, although we know and love our nurse navigators, you know, very well. Oftentimes our nurse navigators are helping patients get to palliative care. Our oncology nurse navigators here are typically meeting people at diagnosis and trying to make sure they get all the stuff done they need to as a new patient in the cancer center. I think it's usually the same at most institutions. They're really meeting people at diagnosis and helping them navigate the system. I wouldn't say that they are usually the same as palliative care, but I say they're always so palliative friendly. Like they love, you know, connecting people with us when it's appropriate.
Carol had a comment. She said, I was disconnected and lost chat. Were there any links posted? Carol, we hadn't posted any links into the chat, but if anyone missed any portion of this talk today, we will be posting it on our YouTube channel and our website in the coming days. So please stay tuned. You can check on our website or sign up for the newsletter, and you'll get the announcement as soon as it's available on the site.
Right. And I think Dr. Kumar, maybe just before she gets off, we'll be able to post some resources, I think, as well. Scott, do we have any more chat questions in the chat room?
Those are the only questions in the chat so far.
All right. So then that means if anyone has any, was reluctant to type, but would like to ask a question, I guess unmute your microphone and fire away. We have time. Scott, are you able to see that?
I am looking to see if there's anyone that looks like they're attempting to turn off their mic. Most people have their cameras off, so I can't tell. But anyone
Shy
who,
group tonight.
well, you also did a really good job with your questions, and you were very thorough with your answers. So I'm sure
Thanks.
that.
So if no one does, if there are no more questions, I think what I will do is I want to thank Dr. Kumar, of course. Dr. Kumar, is there any, you have a group of patients and caregivers in front of you who were interested enough in this topic to give up a little time this evening, as you did as well. Is there any last thoughts you want to give to them before I take the microphone back, so to speak?
I think, honestly, I would advise everyone to, be persistent if you're not getting your questions answered. Be persistent, and just as someone who has helped navigate, my own parents through healthcare, it's amazing. Even with so many medical providers in the family, we can sometimes leave an appointment feeling like, oh, we didn't get to my questions. So I would say, and I say this to my patients when I'm seeing them in clinic, and I take off my oncology hat and I put on my palliative care hat, and I actually tell them, we're going to make a list of questions together. And next time you go to your oncologist, you do not leave that office until these questions are answered. My goal is to empower patients. I think we've taken so much, medicine is paternalistic, and I think we need to change that, or parental, or so much of it is the doctor tells you something and patients do it. And I think we need to move towards more patient-centered care. So whether sometimes your oncologist might not bring up, hey, what's most important to you? What are your goals? I think it's okay for you to say, hey, I just want you to know this is what's important to me. And I think we need to set aside some time to talk about that. So I like to empower patients to request, I'll call it a serious illness conversation from their clinician. It doesn't have to be a palliative care clinician. Your oncologists are perfectly capable of doing this. We do this work. This is what we should be doing. So the resources I'm going to put in the chat are to empower patients to actually make sure their voices are heard. So the serious illness care program is, a program that was started at Harvard. It's a program between the Harvard School of Public Health and Brigham and Women's Hospital. And it's actually sort of a structured way to have this conversation with your clinician. And then there's another, you may have heard of this, it's called the Conversation Project, which was created by the Institute for Healthcare Improvement in Cambridge, Massachusetts. And it also is another way of empowering patients to talk about sort of bigger picture issues with their families. Sometimes it's hard to talk about, our fears for the future with our families, but also a way to bring it up with your clinicians. So I just want to make sure that everybody feels empowered to ask questions, get their questions answered. And if you're feeling like you need an extra layer of support, please make that known. Even if you don't have specialist palliative care, it may generate a referral to either home palliative care or home care. It may generate a referral to your institution's counseling or social work group, all of whom can provide, just an extra layer of support as you're going through treatment.
Thanks, Dr. Kumar. And again, thank you for giving up and even be with us tonight. I'm going to give you a few minutes to get those resources typed into the chat room before I close things out. And the other thanks I want to give is to Judy Nicholson, Kidney Cancer Foundation. They had, they gave me a willingness. I had this idea that there was emotionally related topics that we know aren't being discussed in the doctor's appointments. And also probably a good chance aren't being discussed with your family and friends. And so I had this idea that there was additional support that could be provided. And I shopped that idea around. Judy Nicholson was actually willing to let me go forward with it, which I'm really thankful for. And, it can be intimidating to talk about some of these topics. And I met with this group in April, or a small group of Judy Nicholson people in April, to help me kind of think about what topics were important to them. Palliative care was one of them. Other topics were cultural and spiritual aspects of death, final days, legal aspects of dying, caring for the caregivers. But there are other topics, and these topics will inform what kind of effort or where I direct my efforts to future sessions. But if you have other topics, either you can reach me through Judy Nicholson as well, and get those off to them, because I think that lets me know that it's on your mind, and we can probably find the right resources to address that. And I think we can have a lot of be informing ourselves about a lot of important topics, and I think we'll all be better off for it. So that is it. I think I see Dr. Kumar is okay. She's typing, so we'll give her. I don't know what happens to chats if we end the session, so I guess we should leave the session open until Dr. Kumar is finished, and she'll let us know. Scott, how will people
And
get?
I will also save these links and include them in the website post and the description of the YouTube video.
Perfect. Scott, you have an innate ability to read my mind, because that was my question, was how do I find out if I've already left the chat? Oh,
Yes,
sorry.
sir, I got you covered.
Good. All right, everyone, have a great evening and enjoy the last days, not the last days, but sort of the last month of summer. And I will hopefully see you in another session. Dr. Kumar, thank you very, very much.
Thank you so much. It was such a pleasure to be here today, and I hope some of these resources are helpful to folks on this call.
Sure they will.
Thank you very much.
Thank you. Thanks, Scott. Thanks, everybody.
Thank you, doctor, and thank you to Clint. Y'all have a good day.
Bye.